Hey, everybody. We'll give everybody just a few more minutes to join in before we get started. We'll start at like 3 after.
Like the other stuff is like broad.
Okay. Can everybody hear me okay? Somebody give me a thumbs up or?
Yes.
Good. All right. Y'all can see my slides okay?
Yes.
Yeah. Can I get confirmation? Yeah, good. All right. Okay, so today I want to talk about pulmonary hypertension. Technically some or a lot of folks may kind of consider this a cardiology topic, but I think it's something that a lot of us probably struggle with. So I wanted to spend some time on it. And also who needs another asthma or COPD lecture. So let's get started. So I've got no conflicts of interest. So here are our objectives for today, but basically what I want to cover is what does a hospitalist need to know about pulmonary hypertension? In most cases, this is a disease that you're going to need help with from a consultant. But like all things in general medicine, we need to have a good understanding of the disease process so we know what to order and we know who and when to consult. So today I want to talk about pulmonary circulation. We'll review pulmonary pressures and right heart catheter values. We'll go over the causes, physiology, and classifications of pulmonary hypertension. And then lastly, just hit a few high notes on the pathophysiology of pulmonary embolism as it's related to all this other stuff. Okay, so as is tradition, let's start with a case. So we've got a 29-year-old female. She's got no significant past medical history who comes to the ER after an episode of syncope while running up her stairs at her townhouse. In the ER, she says she feels okay and all of her vitals are stable and within normal limits. Like a good hospitalist does, you take a great history and you find out that she has also had some worsening dyspnea over the last 6 months, and also some fatigue and lethargy over the same time period. And then she also mentions that she feels like she may have gained some weight despite not eating as much and having some early satiety and fullness. So family history, she's got a healthy father. She says her mom had, quote, some heart condition, but she doesn't know much else. And lastly, she smokes half a pack of cigarettes a day and does not drink any alcohol. So you guys can use the chat function if you don't mind, just to type in which answer choice you would choose. So basically, you've got a young, healthy female that comes in with exertional syncope. Which would be the test of choice that you would want to start with? So your answers are, you get CT angiography of the chest, echo, PFTs, and a high-res CT. Okay, it looks like everybody who's, Dr. Bearden with the MixApp reference. So yeah, it looks like everybody wants to start with an echo. So, all right, so you get an echo, and your echo shows no LV dysfunction, a normal left atrial size, no valvulopathy, but it is suggestive of pulmonary hypertension. So cardiology is consulted, and a right heart cath is planned. Which of the following answer choices contain the expected right heart cath values? So each answer choice are just looking at 3 different pressures: our PA pressure, our wedge pressure, and our left ventricular end diastolic pressure. And then your answer choices are just either increased or normal among those 3. Okay. So you could probably guess what our diagnosis is based off the title of the presentation. And so given that, what do you think that you would see on a right heart cath? Need to at least get a couple of answers here, and we'll go through it all. But there we go. We got B, C. Okay. Good. Okay. Yeah. So mostly C, a few B's mixed in there. So let's kind of run through everything, and then we'll come back and visit our case. All right. So you can't fully understand pulmonary hypertension within the pulmonary vasculature if you don't really understand the pulmonary circulation. So let's take a little bit of time to review the blood supply to the lungs. So we have, there are essentially 2 different blood supplies to the lungs. You have the bronchial circulation and the pulmonary circulation. So your bronchial circulation is the bronchial arteries that feed oxygen to the upper airways all the way down to the distal bronchioles. Okay, so think of this as tissue like you'd have anywhere else in the body. And so the trachea and the bronchi and the bronchioles, all that tissue is really thick cartilage, and oxygen doesn't just diffuse from the airway into these tissues. So it has to be pumped there, just like oxygen's got to be pumped to the brain or pumped to skin, wherever. It cannot just diffuse naturally like it can through the alveoli. And so you can think of the bronchial circulation similar to the circulation going to any other tissues. And because of that, the pressures within these arteries are at a systemic level, so roughly 100 to 120 millimeters of mercury. And these arteries branch off, let's see, these arteries are the first vessels coming off the descending aorta, just past your great vessel. So this cross section here is at the middle part of the aortic arch. You have your great vessels going up toward the head, into the arms. But as soon as you start the descending aorta, these first set of arteries that you see are actually the bronchial arteries. So you've got two on each side. You've got your superior and inferior bronchial arteries on the left and the right side. And you can see these are supplying oxygen to the trachea and the bronchus and the bronchioles. Now, one thing that's a little bit unique about the bronchial circulation is that all of the deoxygenated blood that is coming back to the heart actually dumps into the left atrium. So this is different than all the other deoxygenating blood in the body that dumps into the right atrium. And so the bronchial arteries branch off the aorta. They supply oxygen to the trachea and the bronchioles. And then the bronchial veins dump this deoxygenated blood into the left atrium. So we would probably intuitively think our left atrium should be a chamber which contains 100% oxygenated blood because it's bringing that blood back from the lungs, but it also receives just a little bit of venous blood from the bronchial veins. And then just to give a little context as we go into the pulmonary circulation, the bronchial circulation only receives about 2% of all of the cardiac output from the left side of the heart. Compare that to the pulmonary circulation, which is going to be coming from the right ventricle. Every bit of that, 100% of that blood goes from the right ventricle into the pulmonary system. So let's talk about a few other differences here that's somewhat unique. So the pulmonary circulation functions a lot differently than our systemic circulation or the bronchial circulation. So first of all, it doesn't have to be pumped as far. The left side of the heart has to pump blood all the way to the head, all the way down to the feet. But in the lungs, the pulmonary system is really just traveling a matter of a few centimeters. So from the right ventricle into the lungs is a really short distance. The other thing that's a little bit unique about pulmonary circulation is that it doesn't have to overcome a gravitational gradient. So this isn't entirely true because there are some physiologic differences in the top parts of the lungs compared to the bottom parts of the lungs, and gravity plays a role there. But in general, the right ventricle isn't having to pump against gravity. So these two things are important because what this implies, as you would think, is that the pulmonary pressures don't have to be near as high as our systemic pressures. Okay, so the right side of the heart, or the pulmonary circulation, is a low pressure system compared to the left side of the heart, which is a higher pressure system, and it's because of these reasons here. The other thing that's a little bit unique about the pulmonary circulation as well is that it does not have to direct blood from one area to another. And so what this is referring to is, if you've eaten a big meal, the left side of the circulation is going to direct a lot more blood flow to your gut. Or if you're exercising, the left side of the heart is going to direct a lot more blood flow to your muscles. And so there's selected blood flow that has to occur on the left side, and this doesn't happen in the pulmonary circulation. Again, the small caveat is the concept of hypoxic vasoconstriction, which I won't get into, but in general, pulmonary circulation doesn't have some of those hurdles that we see on the left side. Okay, so as in all cartoons, our arteries are usually red and the veins are blue or purple. Of course, things are a little bit different in the lungs, as we all know. So this is a good image of the pulmonary circulation. The heart, of course, has been cut out, but our pulmonary artery is here in blue, and this would be the right ventricle would be here coming up into the pulmonary arteries as it delivers deoxygenated blood to the lungs. Gas exchange occurs, and then it comes back via the pulmonary veins, comes back oxygenated, and all that's going to be dumped into the left atrium. Okay. And then there's this concept of intrapulmonary circulation, and this is where you see some capillary level connections between the bronchial circulation and the pulmonary circulation. So it's kind of hard to see, but here you can see some pulmonary capillary beds feeding into bronchial capillary beds. This isn't terribly important, but in some disease states, like in pulmonary embolism, these connections can help prevent like lung tissue infarction. So it's kind of a duplication of circulation in some certain areas when in states of hypoxia. You see another little example there. Okay, so this is a nice schematic overviewing the pulmonary circulation, and I want to spend some time kind of going over this because it's really the key to understanding pulmonary hypertension is having a good understanding of the circulation and the different pressures throughout the left and right side of the circulation. So we'll start in the left atrium here. So the left atrium, as we talked about, is going to mainly contain oxygenated blood with a small portion of the deoxygenated blood that's been dumped in from the bronchial circulation. But it's a low pressure chamber, and then blood is dropped into the left ventricle where it has to then overcome pretty high systemic vascular resistance because it's got to get blood flow through the entire body. Now, as I mentioned, this right here in your proximal aorta is where the bronchial arteries, the bronchial arteries come out at a systemic level circulation. And then as the blood flows down through all the tissues, by the time you get to the capillary level, you're at a relatively low pressure of about 30 or so. And then we have our gas exchange between the capillaries and the tissues. So we're dropping off oxygen, picking up carbon dioxide, and we're working our way back toward the heart. Once you're on the post-capillary side of things, your pressure is going to gradually decrease throughout the venous system until you get back to the right atrium. So here, this is kind of where your IVC and your SVC would be, and or what you call central venous pressure is going to be pretty low, near zero. And then pressure is quite low in the right atrium, and then it'll pick back up once you get to the right ventricle before it's then pumped out through the pulmonary artery into the pulmonary arterial system for gas exchange to occur again, but dropping off CO2, picking up oxygen, okay? So this is an important chart, and I want to spend a little bit of time reviewing systemic and pulmonary pressures so that these values have some context. So when we start talking about diagnosing pulmonary hypertension, you have a little bit of context of what these numbers actually mean. So of course, in a healthy patient, our normal systolic pressure leaving the left ventricle should be 120 millimeters of mercury. So you can kind of use that as a measuring stick to all of these other values. So we'll start with cardiac output up here. On average, you have 4 to 8 liters per minute being pumped out by the heart. To give you an idea of what that means, you know, our bodies have about 4 to 5 liters of blood total. So within 1 minute, most all the blood throughout our heart or throughout our bodies being circulated and oxygenated. So here are our pulmonary arterial system pressures. Our wedge pressure ranges from 4 to 12. Now, what does wedge pressure tell us? So the wedge pressure is an estimate of left atrial pressure. So notice how our wedge pressure here and our left atrial pressure are identical, and that should make some sense intuitively. So the wedge pressure is a value that we can obtain from the right heart cath that gives us an idea of what's going on the left side of the heart. Okay, so if there's any increased pressures on the left side of the heart, that should theoretically cause some backflow and increase our wedge pressure. Okay. If our wedge pressure gets above about 20, that's when we start seeing pulmonary edema develop. Now, there are some situations in which we have pulmonary edema, but a normal wedge, so that's what you would call non-cardiogenic pulmonary edema. And that's classically what you see in ARDS. Okay, so if the pulmonary edema is from the cardiology, etiology, the wedge pressure is going to be elevated. Okay. Like I said, the central venous pressure is low, and sometimes that phrase confuses people, but essentially if you were to stick a pressure catheter into the IVC, it's going to be your central venous pressure. And notice that the central venous pressure along with the right atrial pressure and the right ventricular end diastolic pressure are all roughly the same, between 0 and 8. And that should kind of make sense because they're all within the same pressure system and anatomically located near each other. Same reason our wedge pressure and our left atrial pressure and our left ventricular diastolic pressure are all roughly the same, between 3 and 12. Okay, so let's look at it a little bit differently. The top part of this graph shows the location of the pressure catheter and a right heart catheterization procedure. And then the bottom part of the graph shows the different pressures. Okay. So here are our pressure catheters coming in through the SVC and into the right atrium, where I mentioned we have relatively low pressures, around 8 or so. And then we make our way into the right ventricle, where the pressure goes up just a bit because it's got to then pump it to the heart. Now the different values here is basically your systolic and your diastolic pressures. Okay, so during diastole, you're on the right side of the heart, everything's close to 0, and then you see the increase as the right ventricle contracts. Then we get into our pulmonary artery. Our systolic pressures are about the same as they are from the right ventricular systolic pressure, which makes sense because the blood's being pumped from the right ventricle. And then our diastolic pressures are a little bit higher, and that's because our pulmonary valve is closing, and so it's providing a higher diastolic pressure. And as we make our way through the distal ends of the pulmonary arterial system, we can obtain our wedge pressure, which, as we said, is around 10. So this is just one final way to look at it, and the graph here, we're going from our pulmonary artery to the capillaries to the left side of the heart, and this graph shows that our pulmonary vascular resistance is decreasing relatively uniformly. Okay, now, and this is a good bit different than what the graph would look if this was graphing the pressures on the left side of the heart, where most of the resistance is actually within a large muscular artery, as opposed to what we see on the pulmonary side of things. All right, so let's get into the definitions of pulmonary hypertension. So pulmonary hypertension is defined as a mean pulmonary arterial pressure greater than 25 millimeters of mercury. Okay, as we said, our normal mean is between 9 and 18, so this isn't a big difference above our upper limit of normal. And then there's different classifications of severity, mild, moderate, severe. But again, even in severe pulmonary hypertension, this is a good bit less than what we see on the left side of things. And it's important to have that context because if you have a sudden acute increase in right ventricular dysfunction, even as little as 40 millimeters of mercury can cause RV failure. Now, if this occurs slowly or chronically, the right ventricle can remodel and handle the slightly higher pressures, but still not a whole lot. Now, this is also a good bit different than the left side of things, where normal systolic pressure may be 120, and somebody could have a panic attack and their pressure shoot up to 190, 200. The left side of the heart has no problems handling that briefly. In the long term, there could be some consequences, but our LV can handle a pressure of 190 without much problems. Compare that to a sudden doubling of our right ventricular pressure, it's gonna crap out on you pretty quick. Okay, so let's talk about clinical manifestations of pulmonary hypertension. So these symptoms are often non-specific, and the problem arises is that the diagnosis is often delayed because some of the complaints are non-specific, and a lot of times we tend to attribute these complaints to a patient's advanced age, or they're just deconditioned, or all their symptoms are due to a coexisting medical condition, as most of these patients do have other medical problems. And as a consequence of this delay in diagnosis, What that usually means is pulmonary hypertension is usually relatively severe by the time we find it, and right-sided heart failure is already present, and prognosis is pretty terrible, often at time of diagnosis. Okay. All right, so in terms of symptoms, the most common symptoms that these patients present with are dyspnea and fatigue. And these symptoms are due to their inadequate increase in cardiac output during exertion, okay? And then some of the other symptoms we see are due to symptoms of their right ventricle failing. And so there can be several symptoms here. Exertional chest pain is pretty common. This can be like classic angina type chest pain. As the pulmonary artery enlarges, it can start to compress on the left main coronary artery and cause ischemia that way. But a lot of times this exertional chest pain is due to increased right ventricular wall stress and increased myocardial oxygen demand, because it's simply overworked. Exertional syncope is always worrisome. These patients can also develop cor pulmonale and have edema and weight gain. And then due to hepatic congestion from the right side of the heart failure, they can have develop anorexia, early satiety, abdominal pain, or bloating. And then we have some less common symptoms such as cough, hemoptysis, hoarseness, palpitations. This hoarseness is due to, again, just as the pulmonary artery can start to compress the coronary arteries, the pulmonary artery can also compress the recurrent laryngeal nerve running down to the mediastinum, also are leading to hoarseness. Okay, so this is a good graph that helps illustrate the progression of pulmonary hypertension. So roughly, pulmonary hypertension can kind of be thought of in three different categories. So you have your pre-symptomatic or your compensated patient, your symptomatic, slowly decompensating patients, and your declining or decompensated patients. So on this graph, you've got on the x-axis is time, and the symptom threshold is here. So as the vascular pathology of pulmonary hypertension progresses, and this happens through like intimal proliferation within the arteries and hyperplasia and fibrosis, you're going to have slow, steady increase in your pulmonary vascular resistance. And initially, the pulmonary artery pressure is going to rise in concert with the pulmonary vascular resistance in order to maintain cardiac output. So as long as the pulmonary artery can increase along with the pulmonary vascular resistance, your cardiac output will remain stable or remain adequate, and the patient will be compensated and often pre-symptomatic. Now, the right ventricle cannot remodel indefinitely, right? So eventually, as the PVR increases, the right ventricle will have to start to dilate to try to maintain stroke volume, and that's when it eventually fails. And as the right ventricle fails, you're going to have a drop in the pulmonary artery pressure and drop in the cardiac output, and the symptoms are going to increase considerably. A lot of times we find patients in this area, and there's not a whole lot that we can do to help them. Okay. Let's talk about pulmonary hypertension classification. So if you take anything away from the lecture, I want you guys to understand how we classify pulmonary pulmonary hypertension. And because if you know the classifications, then the workup and the treatment will become intuitive. So if you can commit this to memory, I think everything else will kind of fall into place. So there are 5 classes. Class 1 is also called pulmonary artery hypertension. So we hear these terms a lot, and it's important to make the distinction here. If you're talking about all classes, all 5 classes, and the disease in general, the term is pulmonary hypertension. But if you're specifically talking about class 1, you call it pulmonary artery hypertension. Okay. So pulmonary artery hypertension is due to a proliferative vasculopathy. So that sounds like a bunch of nonsense. So let's talk about what that means. So this particular class of pulmonary hypertension is due to hyperplasia and hypertrophy of all three layers of the vascular wall. So it's really a vascular issue that kicks us off. And this specifically happens in the small pulmonary arteries down to the arterioles, and ultimately it's going to cause that pulmonary vascular resistance to increase, which finally leads to pulmonary hypertension. And as these small vessels hypertrophy, it can fibrosis can develop. There's vasoconstriction. You can get microthromboses. All those just kind of feed on each other, making things worse. So in our schematic here, our problem for class 1 is here. So it's going to be our small pulmonary arteries leading into the arterioles before we get to the capillary system. Okay. So most commonly, class 1 is idiopathic or hereditary. So there are some identified genetic components to this, but a lot of times it just happens for no good reason. The classic phenotype of this type of pulmonary hypertension is a young female, otherwise healthy female, who has a family history of pulmonary hypertension. Okay. And my voice is getting weaker as I go on. There are other causes that fall into this class 1 category. We see some drug-induced pulmonary artery hypertension. And most commonly, this is from appetite suppressant. So y'all may remember the appetite drug fen-phen that was popular in the mid to late 90s. That drug caused a lot of pulmonary hypertension and was taken off the market. Even some of the suppressants today can also do this. Sorry. But there are also other drugs that do this as well, but your appetite suppressants are most commonly the culprit. Connective tissue disease can also lead to class 1 pulmonary hypertension. Now, this is not to be confused with connective tissue disease causing lung disease, which then causes pulmonary hypertension. Connective tissue disease by itself can lead to some of the vasculopathy we see. I'm sorry, guys. Infections can cause this. HIV is probably the most common one. And then portal pulmonary hypertension can lead to this as well. All right, so class 2. Class 2 pulmonary hypertension is due to left-sided heart disease. So this is what you call a post-capillary pulmonary hypertension. So the hypertension or the elevated pressures are arising from the pulmonary venous system or things downstream to that. Okay, so it's not a capillary or pre-capillary issue like class 1. This is post-capillary. So our problem here is, again, it's by definition, it's got to be on the left side of the heart. So you can have, say severe mitral stenosis right here between your atrium and ventricle, leading to pressure backup, or you're going to have heart failure with reduced or preserved ejection fraction that cause increased left-sided pressures. And yeah, so this is the only etiology that should have, an elevated wedge pressure, right? And that makes sense because our wedge pressure tells us what's going on pressure-wise in the left atrium. So you would think if you've got severe mitral stenosis and that left atrium is having to work against that valve, you should have elevated pressure, and so that's what you're measuring with the wedge pressure. Okay, so class 3 is pulmonary hypertension due to primary lung disease. Most commonly, this is going to be COPD, obstructive sleep apnea, ILD, those kinds of things. But the chronic hypoxia in these conditions lead to parenchymal distortion, which again increases our pulmonary vascular resistance. So this increase in PVR really is the driving force in this whole entity. Okay, so our problem for class 3 is going to be in this area. So if you've got COPD and you've got enlarged alveoli and hypoxia, it's going to be in this area. Okay. As I said, usually COPD, OSA, OHS. Okay, so class 4. This is pulmonary hypertension due to chronic pulmonary artery obstruction. So usually this is from chronic PTE disease, or what you call CTEPH. These patients have developed pulmonary hypertension due to chronic embolic disease. Now, there are other etiologies that fall into this classification, but these aren't near as common. But you can have tumor obstruction of the pulmonary artery, isolated arteritis in the pulmonary artery, or some congenital issues. But usually, if you think, or if you see class 4, you should be thinking chronic embolic disease. So again, our problem is going to be here. Okay. And then lastly, class 5. This is just kind of the catch-all category, the miscellaneous category that contains all the other etiologies. I apologize. So sarcoid and things like sickle cell disease are some of the more common etiologies that we see that fall into this category. All right, so workup of pulmonary hypertension. As I mentioned, if you know the classifications, then your workup should kind of be intuitive. Okay, so there's no one way to approach this. There is this good algorithm I found in a journal, which I can send out, but I'm not going to go through this because it kind of takes things from the beginning. What I want to do is make it a little bit more relevant to us as hospitalists. So there's a few different scenarios that I think that we may encounter as hospitalists, and I want to kind of coach you through what steps to take for each scenario. Okay, so the first scenario is similar to our our opening case. We have an otherwise healthy patient who presents with concerning symptoms, so exertional syncope. In that situation, you start with an echo. Okay. Another scenario, you have a patient with a confirmed diagnosis of a disease which can cause pulmonary hypertension. Okay, so they've got something that you know that can lead to pulmonary hypertension, such as COPD or CHF, and you need to evaluate whether or not they've got elevated pulmonary pressures. Okay, so that's when you start with a right heart cath. Okay, and the third scenario would be a patient who received a right heart cath for whatever reason, and pulmonary hypertension was found. In that situation, you got to go looking for an etiology. So you kind of use your history and your physical and other sources to kind of guide you. But this scenario could be a pretty broad workup and may require an echo, CT angiography, pulmonary angiography, PQ scans, PFTs, sleep studies, high-res CTs, some room labs. Basically, you got to go look for the underlying etiology here. Okay, so in terms of treatment, like I said, if you know the classifications, that should kind of lead you toward your treatment. Okay, mostly for pulmonary hypertension, you want to address the underlying etiology, but I do want to talk about some general categories of treatment. In general, though, I would say once a diagnosis is made, that's when we need to start getting help from a specialist. So kind of the first tenet of the treatment here, treat your modifiable risk factor. So if they've got heart disease, they got ILD or COPD, sleep apnea, address what you can, try to tune those up as much as you can. In terms of medications, you have your general medications that you would treat, weight gain or edema with diuretics, embolic disease with anticoagulation, oxygen as needed. But then you have your targeted therapies for specifically pulmonary artery hypertension. Now, all of these drugs are fairly complex pharmacologically, and these probably aren't drugs that we should be prescribing as hospitalists. But in general, the mechanism of action is to dilate the pulmonary artery to reduce the pulmonary artery pressures, okay? But they all work a little bit differently. There are a few different surgical therapies that you could pursue, things like creating a shunt through an atrial septostomy, which reduces the pressure, pulmonary endarterectomy, especially for your class 4 patients. There's evidence that shows this is much more effective than medical management. And then, of course, you've got lung transplantation. Now, I throw the survival rates up there because they're not great, but neither are the survival rates for pulmonary hypertension. So even if you're catching these patients when they're still NYHA class 1, their average mortality is pretty terrible, and as it progresses, it gets worse and worse. Okay, so I do want to spend a few minutes, and just a few minutes, because I don't think my voice will last much longer than that, a few minutes talking about pulmonary embolism. Now, I don't want to go into the diagnosis or the treatment or any of that. I want to talk about how it's related to some of what we've been talking about up until this point. So the vascular pathophysiology. So say you have a DVT that has been embolized and forms a PTE. When that happens, you're going to have sudden occlusion of a pulmonary artery and a sudden increase in pulmonary vascular resistance. Okay, so we go back to our graph here. We have this, the PE occurs, and we have a quick acute increase in pulmonary vascular resistance. And this isn't enough time for our right ventricle to remodel or hypertrophy to counteract these increased pressures. So you're going to have relatively quick failure of your right ventricle as the PVR increases. Now, remember that the cardiac output between the left and the right side are in series. So the left ventricle can only pump out what it's received from the right ventricle. So as the cardiac output drops from the right side, it's going to lead to subsequent dropping of cardiac output on the left side. So this is important in showing why these patients with large PEs do so poorly. And rarely do these patients die of hypoxia or true respiratory failure. It's more of acute heart failure. So as I mentioned, they get reduced right ventricular output. That leads to reduced left ventricular output. That's going to eventually lead to systemic hypotension, which can lead to coronary artery hypoperfusion, which then leads to right ventricular ischemia and subsequent worsening of our RV output. So you can see once our RV starts to fail, it's really just a spiraling down into worsening cardiac failure. And that's why when you look at the risk stratification for these PE patients, the things that determine whether or not you should just start anticoagulation or pursue more advanced therapies, all that's basically looking at, are these patients showing signs of impending heart failure? And if so, that's when you should pursue a more advanced therapy. So if they've got right ventricular stress on echo or elevated troponin, or they've got hypertension or angina, all those things are signs of this spiraling out of control, and we got to do something quicker than a heparin drip. Okay, so let's go back to our case here. So this was our young lady who came in with exertional syncope. odds are she had pulmonary artery hypertension, one of the heritable forms, class 1. And so we know that since she doesn't have left-sided heart disease, that her wedge pressure needs to be normal. So since both of these had increased wedge pressure, that alone tells us the answer choice here is C. A is what you would typically see in heart failure. So if the left side of the heart is failing, you're going to have elevated pressures at the end of diastole and the left ventricle. You're going to have elevated wedge pressures. And then if things are severe enough, it's going to ultimately lead to increased pulmonary artery pressures. Okay. Answer choice B is consistent with mitral stenosis. So in that situation, everything distal to the mitral valve should be under relatively normal pressures. And so that means your LV volume or your LV pressures will be normal, but your right atrial and your wedge pressure are going to be elevated and your pulmonary artery pressures are going to be elevated, okay? And then as I said, answer choice C was PAH. All right, that's all I got. I apologize for my voice giving out. I've been losing it the last couple of days. I was hoping it would last these 50 minutes, but wasn't so lucky. So do you guys have any questions about any of that? No? Good. All right, there was a good review article that actually came out in the Mayo Clinic Journal this week, and I'll send that out to everybody. But if you have any questions, let me know. Okay. So, but y'all have a good afternoon.